Now coming to various causes of weaning difficulty. The first and foremost is surgical or technical failure, or a most common ventricular dysfunction, vasoplegia syndrome, or it is going to be a left ventricular outflow tract obstruction. In case of surgical and technical failure, your TE will show a valvular regurgitation or stenosis. There might be a patient prosthetic mismatch, paraprosthetic leakage, residual intracardiac shunt, or an occluded vascular graft. In case of ventricular dysfunction, your TE is going to show decreased contractility of left and right ventricle. There is a dilated LV and RV, and there is diastolic dysfunction which shows decreased relaxation. Your hemodynamics, the cardiac output is decreased, your mean arterial pressure is low. In case of vasoplegic syndrome, there is going to be preserved ventricular contractility. There may be a normal or increased cardiac output, but mean arterial pressure will be low. Here the prominent feature is going to be decreased SVR. In left ventricular outflow tract obstruction, there is TE will show the SAM effect, which is systolic anterior motion of the anterior mitral leaflet, and there will be septal hypertrophy and pressure gradient across the left ventricular outflow tract. The incidence, the surgical technical failure is around 2 to 6%. Ventricular dysfunction, which is the most common type, is between 15 to 40%. Vasoplegic, it is 4 to 20%. And left ventricular outflow tract obstruction is 5 to 10% after mitral valve surgery. The risk factor for surgical or technical failure includes a team and operator experience. The more new the team, more complication you can expect. Low surgical volume, severe extended disease, and difficult anatomy. In case of ventricular dysfunction, elderly population, female sex, congestive heart failure, low ejection fraction, diastolic dysfunction, previous MI, COPD, renal failure, extensive coronary artery disease, left main coronary artery disease, reoperation, emergency procedure, combined procedure, and prolonged cardiopulmonary bypass are all risk factors for ventricular dysfunction. Coming to vasoplegic, your preoperative therapy with angiotensin converting enzyme inhibitor or ARB, beta blockers or heparin, high euro score, prolonged cardiopulmonary bypass, and low ejection fraction. You can add sepsis also as a risk factor. Coming to risk factors for left ventricular outflow tract, myxomatous mitral valve, hyperdynamic left ventricle, and a short distance between the mitral valve coaptation point and the septum. Coming to the management, here in surgical technical failure, nothing else. You have to go and redo the procedure. You have to go for a secondary repair or valve replacement. You should close the residual shunt or place a additional coronary bypass graft if the graft occlusion is the cause. In case of ventricular dysfunction, drugs, you have to go with first line of defense is adrenergic agonist, dobutamine, epinephrine or dopamine, phosphodiesterase inhibitor and calcium sensitizer inodilators comes in the second phase. Always have systemic vasodilators, nitroglycerin or NPS if the pressures are too high, and pulmonary vasodilator when the right ventricular afterload is affected. Coming to electromechanical support, you should go for biventricular pacing, intra-aortic balloon pump, extracorporeal membrane oxygenator and VAD, ventricular assist device. In case of vasoplegic, you go with vasopressor, phenylephrine, norepinephrine and methylene blue. In case of left ventricular outflow tract obstruction, you go with maximum volume expansion and discontinue the inotrope and go with negative inotropes with beta blockers. Surgically, you can do a septal resection or a mitral valve repair or replacement. Now, to summarize the weaning difficulty, it can be an abnormal resistance to flow, that is increase afterload or decrease afterload, severe vasodilatation or vasoconstriction, or it can be a blood loss where there is an inadvertent blood loss and hypovolemia is there. Outflow obstruction from the aorta or from the aortic cannula, inadequate ventilation, your lung pathology, the rate and rhythm, sinus rate and rhythm. There should be no rhythm abnormalities. Contractility, you look at the global as well as the regional function of the heart. Miscellaneous, which can contribute to breathing difficulties, hyperkalemia, acidosis, and failure to deliver the drug. Some problem with the SVC cannula, the drug may not be delivered into the systemic circulation, and you can have compromise by lung, pneumothorax or hemothorax, which can also contribute to difficulty in weaning. Valve insufficiency, where there might be a regurgitation or stenosis. Obstruction to inflow, SVC at the IVC junction, and residual intracardiac shunt. These are all the various etiology for weaning difficulty. Unless you sort out these difficulties, you may not be able to wean off cardiopulmonary bypass.